Good evening. Welcome, everyone. Thank you for joining us for this evening's monthly mastery webinar, where we will cover pearls and tips for postoperative patient experience. My name is Lauren LaFave. I'm with Treace Medical. If you haven't joined one of our webinars before, you'll notice that you are automatically placed on mute upon joining, but we really want these to be interactive and encourage questions, comments, and everything throughout the event this evening. So if you'll type those into the questions, the Q&A tab at the bar to the right of the screen, we will monitor those and ask them as we go throughout the evening. And if there's anything that we don't hit on, we'll save some time at the end for any additional questions or to hit on those that we haven't touched upon yet. So tonight, the topics for discussion that our esteemed panel will be discussing are just considerations for pre-op, intra-op, and post-operative techniques, tips, regimens that they will talk about that they do regularly in their practice to optimize post-operative patient healing. And you can see the agenda that we'll talk about here this evening. So as I mentioned, our esteemed faculty, we have Dr. Jody McAleer out of Jefferson City, Missouri, as he just informed us is home to, what is it, Chimp City? Chimp something?
What is it called? Chimp Crazy, that show on HBO. Chimp Crazy. Yeah, watch it. And, you'll see me. I'm with the chimps.
And Dr. Bob Santrock out of Fernandina Beach, Florida. Good evening, gentlemen. Thank you for being with us this evening.
Thanks, Lauren, for having us. Always a good time to be here with you guys.
Good evening, everybody.
So like Lauren said, Bob and I are both consultants for Treace Medical Concepts. So some of the things that you're going to hear today are going to be personal opinion, and some of it is also clinical and surgical insight based upon our personal experiences. So not everything that we state here are particular opinions of Treace Medical Concepts.
And you should be familiar with any literature that comes for the best use of any system that comes out for Treace. So make sure you gather that information before deploying any of their products.
Let's get into some pre-operative considerations. So Dr. Santrock here, as a patient comes into your office, what are some tips that you have for selecting the right patient candidate for these procedures?
You know, one of the great things about Lapiplasty and what it's allowed me to do is make my practice very uniform. And that's everything from my pre-op speeches to my post-op care has become very uniform. And it's really made a lot of things smooth and predictable in the practice. There are things that can cause pitfalls in adopting a very large bunion practice, and you don't want to look over those. And some of those are relatively obvious, but they're worth stating. Neuropathy itself is something that can be problematic, and the biggest thing it's problematic about is it's subtle. And most cases of neuropathy in the United States are associated with diabetes, but not all. And so you need to be keenly looking for subtle signs and questions that can lead you to the diagnosis or the probable diagnosis of neuropathy, because neuropathy changes the protocols. And we're going to talk about our protocols as we get going on here, but the system was designed within a near immediate or early weight bearing protocol, and neuropathy, even if subtle, can affect that. And so we want to be careful about that. So I'm very cautious about it. Diabetics themselves, one of the worst things that I think has happened has how we have diagnosed diabetes. I think it's a travesty what's going on in the diagnosis of diabetes. I myself am a diabetic. I'm personally very, very interested in this topic, and I can tell you that it is almost without a doubt it's an inherited disease. So when we diagnose diabetes, we're diagnosing it way at the point when complications occur, not when you can be preventative. So there's this whole period of time when people are starting to tease around with being obviously diabetic, and we're calling them pre-diabetic. This is not doing anybody any good. And so you, as a specialist who's going to intervene, the pre-diabetes might be just as dangerous of a diagnosis as diabetes. It doesn't mean you can't do surgery by any stretch of the imagination, but you need to be careful and cautious when somebody says, oh, I'm not diabetic, I'm pre-diabetic. That means they have diabetes, right? It probably is inherited, and you need to be taking those extra cautions, looking at the A1Cs yourself, making sure that they're having the best nutritional balance when they're going into surgery. And lastly, smokers, you know, a lot of people, this is fading. Thankfully, in our population, people are stopped smoking, but they're still vaping. So there might be some oxygen deprivation to the tissues based on competition with carbon monoxide. That might still be a problem. So be careful about that. Again, I have relaxed on this some over the years because the data just doesn't support absolute zero smoking as I used to do. Not in these cases, but I still prefer patients to not smoke. If you are in a high smoking population, there are probably some tricks you can look forward to in trying to do this. But one of the easiest things is to try to make sure that your incisions are appropriately sized, maybe smaller. And if you have a struggle through small incisions, maybe you need to make them bigger. Incisions will heal side to side, not end to end. So don't be pulling and tugging and treating the tissues mean that in patients who have had a history of smoking. One of the things that's been shown in the literature is that if you smoked for 12 pack years or longer, there is irreversible damage to the microvessels. So even if they quit 40 years ago, the microvessels in the foot and ankle might be susceptible to damage that will be detrimental to your healing. So be cautious that just because they quit doesn't mean they're perfect. But again, each patient should be individualized, in my opinion.
Hey Bob, I have a question for you. What about your marijuana users, right? So that's still in the forefront currently. So many states across the U.S. have legalized marijuana, and you know, while some people are using edibles, you still have people smoking or vaping the different components of the flower. So do you have any threshold as far as your go no go for patients that are regular users, and kind of how do you draw the line in the sand on that?
Well, I think this is a great discussion point that we need to explore further with all surgeons. But I would tell you that, you know, tobacco smokers have the deal, people who smoke cigarettes are dealing with a lot more toxins that are probably the detriments, not the nicotine, probably nearly as much as we put weight on it. Nicotine actually has been shown in some studies to be beneficial to bone healing. So it's kind of hard to tease it out, but probably all those toxins in the smoke and the competition for oxygen receptors on our red blood cells is where we're running into trouble with cigarette smoking. So I'll put that at the worst category. And then people that are cigarette smokers habitually smoke more cigarettes per day than people who smoke marijuana on average. So there's some volume contraction when you move to the marijuana smoker. What we don't know is the vapor, because a lot of times now vaping is actually happening more than cigarette smoking. So in volume, you're doing it more. But the toxins, a lot of the toxins have been removed or replaced with some other toxins we don't have as much familiarity with. There probably is less of the competition for the oxygen, but we haven't proven that out. So I think all three right now, for me, I put them in the same category, but have a very distinctly different appearance on my cigarette smokers. Probably longevity, the largest volume of people we can look at as far as studies go. It's not really teased out yet, but I think I can rest a little bit on the fact that a lot of people that are doing marijuana are probably vaping more, probably less toxins than that, and they're probably not doing it as frequently as the cigarette smokers would be, at least the volume of smoke inhaled. So that's
Yeah,
my opinion on that.
yeah.
Completely going to evolve over time.
Yeah, we often talk to the patients about that. We often suggest to them that they eat it, they don't smoke it, just because of that unknown factor, and also, you know, unknown understanding. Because we have some patients that come in that are professional users that are using, you know, 100+ milligrams in a day. We have other people that are just very recreational, where they may just take a couple of milligrams during the course of a weekend. So it is kind of an interesting conversation, as well as the carriers that are in the vaping, whether it's for marijuana or tobacco. Some of the propylene glycol and the different chemicals, they've been shown to crystallize in lungs, causing permanent lung damage, which leads to difficulties with the oxygen carrying capacity, like you stated, getting that lung membrane to function appropriately to bring the oxygen across it and to feed those red blood cells. That's very concerning. Similar to the popcorn lung phenomenon that they saw with the microwave popcorn, they're seeing very similar findings in some of the studies with the patients that are vaping. So always something to be cautious about, and to have open conversations with your patients.
So kind of getting into nutritional recommendations, and this can be we're talking preoperative here, but maybe we extend that a little bit to kind of throughout the entire course of their time as your patient. Dr. Santrock, I think these are yours.
Yeah, I think Jody and I do this similarly. I think we both give a little bit of data and information to our patients about nutrition. To me, when I meet a patient and we've decided surgeries in their future, but even if it's not in their future, they have a musculoskeletal problem. And I really want my patients to get as much musculoskeletal health as they possibly can for a lifetime. So none of this would be detrimental to anybody to do for a lifetime, except for the protein supplementation takes some nephrology patients to be cautious with. But when I do sign somebody up for surgery and my lead time to surgery is probably a couple of months, I do tell them to get on this regimen and then continue it for a minimum of 4 months post-op. Now, I like a lot of people to stay on vitamin D for the rest of their life, but these are the elements that I've focused on. Essentially, the most important of these for me is vitamin D, and this is kind of my minimum vitamin D. I actually prescribe much higher doses than that if people will accept it. So usually 10,000 units a day on vitamin D if they'll agree to it, which most of my patients do now. And in that supplement, it has zinc, calcium, and magnesium to help with the metabolism. But you can get that through a multivitamin as well. Vitamin C, and then vitamin D is the body's anabolic steroid. It repairs everything and builds proteins and muscles and everything. So to me, vitamin D is absolutely clear at this point, associated with complications if low, and it's something that we are responsible to be sure that it's good. Now, coming directly from this, Jody, I'll ask you, do you check vitamin D levels? I personally have gotten away from it, but do you check them?
I used to check them, but we started having problems with insurance not wanting to
Right,
cover the lab. Yeah, so
right.
we've gotten away from it. But if the patients are willing to potentially have a small out-of-pocket lab fee that, after we charge it back to the insurance and it gets declined, sometimes the patients have a responsibility to it. So then we will offer it to the patients. But again, in our area, and we talk about this all the time, Bob, our patients in our region of the country, we're in the Midwest, we're not getting a lot of sunlight multiple months during the course of the year. So we are mostly either deficient or insufficient. And so we're supplementing everybody across the board. And what we typically do is 5,000 IUs of vitamin D3. And we've also started to include K2 into the mix, vitamin K2 specifically just to help to drive the calcium and other key minerals into the bone, which there's some studies out there that show that that's beneficial.
I think it's interesting data that K2 can be synergistic with the vitamin D. I haven't gone that route yet because I don't have enough information for myself personally to feel comfortable, and K2 could be imbalanced with blood clotting and stuff yet. Haven't seen any negative reviews yet, but I'm just trying to learn myself. It's a new way. Other things that help, vitamin C is very helpful to the immune system. Obviously, we want patients to stay healthy, but it's also very helpful to nerve endings. Vitamin C has a de-excitement value to nerve endings, so the hand surgeons are very big on this, and so I adopt that as well to prevent possibilities or to reduce possibilities of things like complex regional pain syndrome and such. Um, Protein supplementations. The only thing I add in caution here is that if you are a kidney uh, uh, disease patient, you need to clear with their nephrologist how much protein they can take in. I've twice asked them to do protein and had twice patients their kidney values change quickly, and so the nephrologist knew, and then they told them to stop. So anybody that has that, I alert their nephrologist or have them alert their nephrologist and monitor. But 30 milligrams twice a day is not hard to supplement. That's usually your little containers of protein supplement shakes that you can get relatively easy. My view of this is you're going to use all this stuff up during surgery, so have the tanks full and keep them full. And that's the way I look at it. And on the foods, it's basically we're going to talk about get away from carbohydrates, which create inflammation. We need to control the appropriate amount of inflammation during this post-op period. They also are burning and wasting energy and calories. So this is going to be harder on your body. Supplement it with meats, beans, healthy vegetables. I allow peanut butter because peanut butter is a good, easy way to get something with high amounts of protein, even though it's got sugar in it. It still is a very good utility medicine food for people. And I try to increase your water intake. And again, this rule basically says my grandmother told me this. She says if it tastes good, spit it out. It's bad for you. So yeah, that's Grandma Heater. She told me that. But I think that it's a good rule in general to do. And now, how much do people follow this strictly? Probably not much. I have gone to where I'm using vitamin supplementations by prescription, so that is getting done. But the foods, who knows?
And you can
So
get really in the weeds on this too. I mean, you can even go into discussing with your patients from a nutritional standpoint, which we do at our practice, staying away from seed oils, canola oil, safflower oil, sunflower oil, any type of vegetable oil derivative, which have all been shown to cause increased inflammation in the human body, everything from cardiovascular and heart issues, and moving towards an organic, non-GMO diet. I know it sounds very hocus pocus to a lot of people, but even going to things like grass-fed, grass-finished beef, good protein sources, and also making sure that when you're getting a protein supplement, that we're getting one that is free of mycogens and other heavy metals and toxins. And so kind of looking deep into that and putting together a nice protocol for your patients that you can justify and work through with them so that you can decrease any type of inflammatory response and any type of amplified inflammatory response they may face post-procedure. So use food essentially as medicine, as a potential benefit for them, along with all the other traditional things that we do.
So Dr.
Absolutely.
Shields made a comment or typed in a comment here, and she said, in regards to vitamin C, please know that if the patients are using a continuous glucose monitor, vitamin C levels greater than 500 can affect the accuracy of the readings.
That's 100% true.
Very
good comment, Dr. Shields. We appreciate you reminding us of that. We do tell our patients who are on glucose monitors to watch that, but absolutely, it's worth repeating here.
Yeah, and I think, this shows, Dr. McAleer, you're pretty on point, right?
Yeah, I mean, we just kind of touched on this, but the other thing I would just touch on that I didn't speak to is also vitamins. When we're talking about vitamins, there is a significant difference between the types of vitamins that are over the counter and on the shelf. There's vitamins out there that are very low quality, filled with fillers. We want to be looking for vitamins that are food sourced based, vitamins that are active and methylated. Some patients, when taking vitamins, have a difficult time phosphorylating and methylating their vitamins in their liver. So they take these large quantities of supplements post-procedure and leading up to their procedure, and they're not getting the full benefit. And even in some instances, that can lead to irritation of liver, inflammation, toxicity, and so on and so forth. So these are just things to consider because even vitamins such as B vitamins, everyone talks about B vitamins being water soluble, but we diagnose patients annually, probably anywhere from 5 to 7 patients annually with vitamin B6 toxicity because they're taking low quality vitamin B sources, doing power drinks like the energy drinks, and then adding on top of that their vitamin regimen, and they're getting the worst source of vitamins possible, and their bodies just can't metabolize it, and it can lead to paresthesias and neuropathies and other things like that as well. So something that's a quality supplement, paying those extra couple of dollars, doing a little bit of research and knowing what your sources are really will help your patient immensely.
Yeah,
vitamins
they're not regulated by the FDA as a
Correct.
whole, but there are regulated versions of vitamins by the FDA. They're called medical foods. It's a whole different category that has to guarantee potency and to guarantee purity of the vitamins. So there are some companies out there that do have regulated vitamin supplementation. They're technically by the FDA categorized as medical foods, but to you and me, they look and act just like a vitamin. They're just guaranteed for the purity and the potency. So you were saying?
No, just one last thing to hit on that's on the bottom of the slide here is BMI. So we talked about diabetics, we talked about smokers, talked about BMI.
Yeah, we want our patients to be set up for success. And while I feel very comfortable that a patient that has a BMI of 45, 50 or greater, the hardware will likely hold up in those feet. My concern is the patient's ability to appropriately function post-procedure and be able to carry themselves in a safe and cautious fashion and be able to comply with my instructions after surgery. Now, we will get into this more, but we let these patients bear weight post-procedure in a protected fashion immediately and have done so for years now. But we want to make sure that the patient is always, again, going to be optimized. So we really, really try to get them under a BMI of 45 if possible. Our facility has a hard cutoff at 50. We try to get everyone down to 45 or less, and that has been successful, I find.
Dr. Santrock, are you on the same scale as this? What do you tend to lean towards here?
Yeah, I don't personally have a number, but I do follow Jody's guidelines in general. If somebody's BMI is greater than 45, the biggest concern I have is their overall health is depreciated. Despite what you might think, obese people typically are malnourished, and so I would check their nutritional parameters pretty stringently. So I look for an albumin to be greater than 3. I like it greater than 4 if at all possible, and I like the total lymphocyte count to be greater than 1,500 on the CBC with differential. And if they're not, then I actually ask them to do nutritional regulation to get it to that point. And so the BMI in isolation isn't my concern as much, but does tend me to look into their nutritional status before surgery. And again, it might be, paradoxical, but they tend to be malnourished, have low proteins and low albumin, low lymphocyte count, which is a reflection of nutrition. So I think that's an interesting point.
Yeah, part of the whole package, right? So then going into preoperative considerations, now talking about the patients coming in and the deformities that they're presenting with, how would you tackle some of these bullet points here?
I think the one that really sticks out to me the most, and the one that I hear from colleagues the most, but one that we don't necessarily face in our practice, is I don't want a big toe joint fusion. And often patients come in and they feel as if they're going to have a stiff first ray, they're going to have a stiff great toe. It's going to preclude them from being able to run, jump, do cutting motions, wear specific types of shoes, and so on. And there are 2 papers that were published here in the last year and a half. One was published by Paul Dayton and Mindy Dayton, and another we had co-authored with Paul and Mindy. The first paper they wrote was on MTP fusion. We wrote a paper also on the double TMT MTP fusion. And the point of the paper was not to assess the radiographic benefit or the just overall clinical appearance of the patient's feet in the study, but rather a retrospective evaluation of the patient perceived outcome post-procedure, asking patients, what can you do after surgery? How are you doing after surgery? How do you feel? What activities have you returned to? And the resounding answer in both of these patients, 2 separate patient cohorts, patients were able to do physically more after surgery, including running, jumping, inline activities, cutting motions, as well as things like yoga, which you would anticipate needs flexibility. So these patients are maintaining or increasing their activity and doing more simply because the first ray is realigned, the deformity has been reduced, and the foot is now functioning in a heel-toe fashion again, and they can do it in a pain-free manner. So I think that big toe joint fusions are one of my favorite procedures, and we do them with regularity.
I mean, I'm in the same camp as Jody here. I don't find this to be nearly as difficult as the consults we get from colleagues around the country who tell me this is an impossibility to get over this objection about big toe fusion. Yeah, maybe the concept starts with me identifying to them what their problem is, which is that they may have come in telling me they had a bunion, and I diagnosed them with arthritis and show that on the x-ray and on the clinical exam. And then I show them this algorithm and say, this leads us down to these pathways and how we have to do it. And of course, I use things like language of such as like, if I realign your toe and it's already a bad arthritic joint, it might make it more painful. So I don't find this conversation hard in my own personal experience, but I think it's our job as surgeons to not do what the patient wants, but to offer them what they need. And if it doesn't match their need, be willing to let them walk away. Nobody's going to die of a bunion or an arthritic big toe, so it's not like you're letting them go off and to put themselves in harm. So if they don't like the advice you give them, it shouldn't be an insult to you or a worry that they're going to go down to the street to your competitor. you should offer what is appropriate. And this algorithm is very helpful to me. I actually took this algorithm, redid it myself into layman's terms, and it looks exactly the same, but then they can see, well, you came in, you said you had a bunion, we actually diagnosed you with this, and here are the options as we go through that algorithm. And the other part of the language here Jody and I always ascribe to is that every one of those surgeries on the right-hand side are Lapiplasty surgeries. So if somebody came in for Lapiplasty, we consider all of those, including a big toe fusion done triplanar correction, is a Lapiplasty philosophical family of surgeries. And so we are comfortable with that because all of these lead to the same post-op recovery for us. It doesn't deviate. So I can do a quad, a double, a MTP fusion and isolation, an adductoplasty or a Lapiplasty, and they all will lead me to the same post-op protocol. So this takes the anxiety out of offering it to the patient, that it's not worse, it's the same post-op protocol, and you're going to have the outcome you're desiring. So that's how I get around this misconception.
So second bullet point here, we kind of labeled these as distractions. Patients that come in and have bilaterals, are you performing bilateral bunion surgery or bilateral triplanar bunion surgery on your patients?
I've done it, and I've failed it 2 times. I tried it, and when you fail at doing something, you don't tend to want to go back and do it. And when I mean fail is that the 2 bilateral cases I did, I had a complication on one side that required me to go back. So on both those patients. So I think that it's a no-go in my hands. I think it's too much for them to rely upon. Also, it just doesn't speed things up. It slows them down. They get, neither foot does well post-operatively, in my opinion, and therefore they stretch out both feet to the equivalent of sequential feet in my cases, with more complications, swelling and pain. And by the way, if you want your patient to like you so because you conceded to do bilateral feet, the rest of the family hates you. That nobody loves the person who has both their feet operated on. But by the end of a week, they decided that person would be better off out of my family because they're such a burden. So you need to be cautious about what bridge you're burning by conceding to this. That's my harsh opinion.
Yeah.
I failed at it before, so I got that bias, I guess.
Yeah, I agree with Bob. I will sometimes stagger the feet. So instead of making the patient wait till 4 months, I'll sometimes do their second foot at around 12 months if they're doing well post-procedure. But we do discuss it with them ahead of time when they request it, and we tell them that we will schedule them for both feet in that fashion with that gap. But we reserve the right to push them out further if we don't feel as if they've made enough progress and they're not moving well enough. So
yeah, I agree with
Dr. McAleer. 12 weeks, 12 months. You said 12 months, 12 weeks, I think.
Oh, I apologize. Yeah. 3 months, 12 weeks. I apologize.
Got it. Yeah.
Yeah, my minimum is 3 months. I like to get to 4, but my minimum is 3 months as well.
Yeah, same.
So on here, monster deformities, maybe we talk about the image on the center or all the way on the right, just these patients that come in with a lot happening in the foot. How do you approach those conversations? How do you decide what procedure to do with them?
Radiographic assessments, so the image on the far right, you can see that patient has obvious evidence of metatarsus adductus. So we co-authored a paper, Bob and I, on a technique called the plumb line to assess for this, to give a clinical and radiographic go or no go assessment of does the patient have adductus and should they potentially have adductus surgery, which helps to drive those conversations with the patient. Because like you said before, patients are coming in, they're asking for their bunion to be fixed, but they don't know what's behind the scenes. So when you show them their x-ray, it's our job to very simplistically explain to them, that they have something else going on in these instances. So they have a bunion plus, right? So we need to do a 3-2-1 angular corrective instrumented arthrodesis for these patients to get them honed back into the longitudinal axis of the foot. So plumb line is as simplistic as it gets, in my opinion, for the patient to understand why you can't move the first metatarsal back over, because the lessers are in the way. If we move the lessers out of the way, we get a better Lapiplasty. And I think that's a very, very organic conversation. So that's how we go about some of these more complex situations.
And this middle picture here is, what the surgeon needs to identify here is that this is not just a forefoot problem. That we have midfoot deformity and probably hindfoot deformity going on as well. You have to be comfortable with how much surgery you can offer and to what extent. I think some generalized rules are, only operate on what you're comfortable with in the setting you're comfortable with. I like to limit everything I do to no more than 2 hours because I feel like my complications with tourniquet time gets worse and post-op patient pain control becomes worse. So I try to limit my surgeries to 2 hours. So I stage things, and if I stage things, I work from the hind foot forward. I work from the calcaneus forward or the ankle down, calcaneus then forward. So if I need to do a triple or I need to do a hind foot realignment, with a subtalar fusion, it's probably going to stage in my hands. Now, if I'm doing something simple and small that I can add on, like an Evans osteotomy, which this case is beyond that, Evans would be the reverse of what you need to do here. It's different, but I'll add on small things, gastroc, a hammer toe, something like that. But be mindful that you want the patient to have maximal recovery. They're going to have to be active postoperatively, and that doesn't mean jumping jacks, but it means mobile enough to not get a blood clot and mobile enough to not lose all their muscle tone in their leg. And so think about staging sometimes is often better.
All right, so moving on here, let's talk about some pearls intraoperatively that you guys do regularly that really help to advance or help the patients post-operatively. Start with some OR setup. Maybe Dr. McAleer, you start with your images on the left-hand side here.
Yeah, so what we found is that not only does our preoperative examination of the patient, x-ray taking of the patient preoperatively, and discussions with the patient preoperatively with this plan to move forward have to be consistent. Not only does our surgical technique have to be consistent, but the way that we set our room up has to be consistent, and the way that we take x-rays intraoperatively also has to mirror that, because if we don't understand what we're seeing radiographically as we migrate through the procedure, that can lead to errors in judgment and misunderstanding of what's going on from a radiographic versus a clinical assessment. So what we started doing was we tried to keep the C-arm completely stationary during the procedure so that the only thing that's moving is the foot, and we can really control for some of those variables that happen while we're operating. We don't want to fight with the C-arm, pull that in, pulling in the leg at the same time, moving two things at once, and maybe not getting a very good beam angle. So we take the patient's non-operative limb, we put it in a lithotomy stirrup, we drape up to the leg, we use a thigh tourniquet, we tuck the drapes underneath, and we put the C-arm flat on the operative table so that we can keep that C-arm stationary and get the very best x-rays possible. And it allows us to manipulate the limb, and we can get a Treace AP, a weight-bearing AP, a lateral, and then we can also shoot a sesamoid axial from this position. And we can do these things rapid fire with foot pedal control, and it makes it a really, really nice process, and it cuts tons of time off the surgery. So that's one of the biggest benefits I found to this technique is time and efficiency and consistency.
Dr. Santrock, this is a newer setup for you, for your images here?
So I adopted the two things that I adopted from Jody was moving the well leg into the lithotomy stirrup off the bed and standing up to do surgery. I was taught sitting down for most of my forefoot surgeries, and now I stand up. And some of this was influenced by the fact that I use a different type of C-arm, one where the emitter and the receiver are no longer attached with a C. And so I can use the entire receiver as the plate where I operate. So that's that white structure on the far right picture laying underneath the foot. And then I swing my arm in and out, but it's fixed. All I'm doing is swinging it out of the way of my working. So it allows me to still work over the top of the foot like Jody's working, where he works from the dorsum of the foot. I work most of the time from the foot of the bed over the medial side of the foot, but allows me to go both directions. So again, like Jody though, I prep, I do a thigh tourniquet, and I prep up. In my case, I prep only to the knee. That's the blue towel wrapped around the knee. Jody preps all the way up to the thigh, but you can see his drapes end at the knee. This allows you to bend the knee to get that lateral picture. allows you to manipulate it underneath the stationary receiver of the C-arm. So we're doing the same thing, we just have different machines. The one thing I do differently, I think, than Jody is that I use a bilateral drape. So I put a Mayo cover like he does over the well leg, but then a bilateral drape allows me to bring out my emitter. You can see that the clear plastic is coming out of a hole in the drape, which is the other leg of the bilateral drape. So something there that works for me. So the tourniquet, him and I both use it the same way. Speaking of tourniquets, thigh tourniquet for me is my preference, and I like 225 millimeters of mercury if I can get it, or better, or lower, I should say. 225, there's scientific studies that show that the free radical production and postoperative pain and postoperative bleeding is decreased with 225 millimeters of mercury or less. You get 225, that's when you start getting toxins and build up, and it creates more postoperative pain and bleeding. I was taught this by residents when I was teaching residents at Western University, because they had one of my other partners was covering call, and they were doing an ankle fracture, and he wouldn't let them put the tourniquet on at all. And he said it was for these reasons, and they didn't believe him. They went and looked up the literature. They brought it to me and said we shouldn't use a tourniquet. And I said, well, why don't you do what the paper says? It says 225 millimeters mercury, and it's fit my satisfaction that I don't like to look at blood. And you have to have some cooperation with your anesthesia, but to make sure they don't get hypertensive during the case and control the pain. But if you use post-op blocks, you can control the pain. And Jody, use regional blocks, correct?
Yeah, I do. And we use a combination both Marcaine plain, 0.5% Marcaine plain, and we also use EXPAREL, which is very beneficial for the patient because it lasts for approximately 72 hours in many instances, and you can mix it directly with Marcaine or saline to dilute it. And so you can't just inject the EXPAREL in one single bolus, kind of like a ring around the surgical site. You have to pepper it in. So I usually drop my 25 gauge 1.5 inch needle. I drop it into the hub. I inject and draw out, and I move the needle from distal to proximal every 1 to 1.5 centimeters, and I just keep dropping wheels all around. And I find that the patients really at this point don't take anything significantly beyond 800 milligrams of Marcaine. I'm sorry, Marcaine, I apologize, Motrin, ibuprofen. And on very rare occasion are they actually taking their narcotic when the block wears off several days later. So it's worked out beautifully for us, and it keeps the patients from having that nausea, constipation, issues with sleep, and so on. So it's been a game changer.
Yeah, I use the EXPAREL as well. I do it as an ankle block in the pre-op area, so I block all mine as an ankle block with the EXPAREL 50% 0.5% Marcaine 50%, and it's been an incredible postoperative pain recovery. The vast majority of my patients tell me they don't take any pain medicine post-op day 1, post-op day 2. You get to post-op day 3, they take an average of 2 pills, and post-op day 3 or 4, whatever I'm up to, it's 2 or 3 pills. So we're averaging like 4 pills total narcotics, and it's a terrific lead for us because of all the regulations with narcotics, but also patients feel better when they're not doped up on narcotics. So EXPAREL is it's indicated for bunion surgery, so you do have the actual medical indication for it. It's been scientifically published. Also for total ankles, for those of you who are doing those as well. So I do mine as a pre-op block. Jody, you do yours intra-op, I guess, or post-op?
Yes,
or
that is correct.
Okay.
Yeah.
Yeah.
Yeah,
There you go.
and yeah, some of the other literature out there is for hemorrhoid surgery. So I mean, I guess bunion surgery and hemorrhoid surgery hurts. So, but those were the original publications centered around EXPAREL. So it has a lot of good data on it, like Bob said. So
Talking tourniquet, Dr. Santrock, at one point you had contemplated maybe going no tourniquet here, but you did hit on it already, but just maybe
I
talk
tried
about
it.
a little bit.
I tried to go. I didn't go no tourniquet. I tried to go S-mark only. We had some colleagues that were doing S-mark only. They sent us some data that with S-mark at the ankle with 3 turns around the ankle gave equivalent to 200 to 225 millimeters of mercury pressure control. So I tried it, and it was not successful in my hands to prevent enough bleeding for me to like it. Plenty of people do that, and you could bet that if you do a typical 4-inch S-mark 3 turns around the ankle, it's going to give you about 225 millimeters of mercury. So theoretically, it should be as scientifically good. So if you can get good bleeding control, then that's equivalent to what I'm doing at the thigh. So for those of you who are not prepped to the thigh surgeons and don't like that, understandable, and you can give that a go.
It really seems though, Bob, I mean, I know we're in agreement on this. It's easier to have the thigh tourniquet on. I mean, the surgery goes better. It goes faster. You're not getting stuck in the drapes. You're not getting tethered when you're operating.
I 100% agree. Yes.
I think it changes everything. So if you haven't tried it, maybe give it some consideration.
One more comment from Dr. Shields here. Did she say she still drapes above the knee to have movement, but you need to pull the 3 or the 4 out to the 3 to put the remainder at the lateral aspect of the muscle, so you get less ischemia.
A 4-inch tourniquet as opposed to a 3-inch tourniquet.
Yeah. Yep.
Yeah.
All right. So kind of hitting on a few more intraoperative pearls here. First one being as it pertains to postoperative experience and success, incision, dissection. Get hit on this briefly.
I'll tell you that when we approach, whether it's an MTP or first TMT, we are essentially to the bone. We identify our landmarks, we identify the tendon sheath, we know our path, we do these procedures a lot with comfort. So as long as I know where that tendon is, we're going straight down. And I find that's far less traumatic, and we try to reflect the tissue in a full thickness flap with as little undermining as possible and as little tissue handling as possible. Because gripping, squeezing, touching edges, pulling on the patients, those are the things that cause trauma to the tissue. And of course, surgery is essentially the way that we describe it is it's trauma with a purpose. I mean, we're inducing trauma in order to get the job done, but we want to touch the patient as little as possible. And often we talk about this in the operating room when we're working, and I talk to my techs and my assistants, and I'll tell them, you know, the patient is sleeping right now, so they can't complain to you that you're physically causing them pain or discomfort when you're touching them, but you have to be their advocate while you're operating, and you need to be gentle, and you need to move precisely in and out of the surgical field with a purpose, and not just sit there and pull and yank and retract. And so if there's no activity currently and we're working on getting a package opened or something put onto the surgical field, nobody's touching that patient. And we do a lot of one-sided, very gentle retraction so that we're just seeing what we have to see, and we're not pulling and stretching the soft tissue wide open. I think that's really important for swelling and everything else we're talking about.
Yeah, I would say probably the majority of these pictures with the 2 SIN retractors in there probably rarely happens in our ORs because we're really not working in that fashion where this is for illustrative purposes. In the middle picture on the top, you can see that the forceps are being used to pull, but they're not pinching, and that's really important. The blood flow for the entire foot is running through a single layer about halfway between the surface of the foot and the bone. And if you are spreading and dissecting layer by layer, you're disrupting the perforators that are coming off that single layer of vascularity. And either the skin or the bone is going to get less blood flow. So by peeling it off with the periosteum, which we do, which a lot of times people are counter like, oh, why are you peeling the periosteum off? You're going to kill the bone. Well, I'm peeling it off as a layer. I'm going to lay it back on. So it's going to likely get restorative of the blood flow more quickly. So I think it's important to realize that we're purposefully, as Jody said, approaching this tissue. And the other thing to remember, there is a nerve that crosses the typical Lapiplasty incision. That's it's one of the superficial branches of the dorsal cutaneous nerve to the great toe. And trying to preserve that, if it's in your surgical incision, is likely going to lead to more pain and neuroma formation than it is to sacrifice it. So if I see it, I cut it. If I don't see it, I've probably cut it. And that's what happens in my OR. I tell the patients they're going to have numbness at their great toe where the medial eminence once was, and it ends up being about a dime size at a year. I've never had anybody complain about that, but I had a few times when I tried to preserve it, of course, had pain associated. And I think as the medical monitor of all of our long-term studies, I think the majority of our hardware pain is actually nerve pain, when people have not cut the nerve and let it sit there, and then it's neuritic type pain. I think it's something to keep in mind. If you're having a lot of what quote unquote hardware issues, you're probably having neurologic pain secondary to that nerve being pulled and tugged on and leading to neuropraxia.
Getting into soft tissue releases, so dissection, what is the importance in terms of thinking later on down the line for healing? What's the importance of thorough soft tissue releases?
I think these are Bob's X-rays here. Bob, these are yours, right? These are your
Yeah,
fluoro.
this happened to me. And so I'm zipping along and I forgot to do the lateral release, and I'm trying to figure out why the reduction won't work. And and I'm not, then I'm looking down. I finally realized there's no incision between the toes there, and I'm like, oh, I forgot to do a lateral release. So I do a lateral release, and then it just reduces, no problem. So it's just lesson learned that adequate, proper releases both at the MTP and TMT are needed to get this reduction. And so it makes a big bearing on if. And here's what happens if you don't adequately release: you're overpowering it with the mechanical advantage of the instruments. That's not what they're designed to do, but you're fooling yourself into thinking you have it released. And then as soon as you remove those instruments, it bounces back, or we call spring back, and that can lead to a disappointing reduction long term. And so I think that's the importance of this, is that what Paul Dayton coined a couple years back. He said we were all doing tricks to manipulate the tissues to try to get this reduction until we found out it was adequate. And Paul coined the term natural release. And that turned out to be the way we wanted to go. And it should feel just naturally going in without too much fuss.
Yeah, and if you and Bob's talking about the best case scenario that you have a problem, you get a little bit of spring back, but even worse would be an overcorrection, a fracture of the second metatarsal, just due to that constant over tightening. And we do see that sometimes when docs are first getting trained. So just kind of having a reasonably light touch, that position or knob, you should be able to rotate it forward and backward with ease. It should not be cinched down so hard that you're potentially going to induce some bone injury there.
And maybe just speaking a little bit to the compressor aspect of it. So we know we don't want to over tighten the positioner that we see in the top images. We want that to be nice and natural. But what about the compressor itself on maybe the bottom image?
It's going to be a similar feel for me, Lauren. I mean, Bob talks about a 3-finger tightness, and I think that's an adequate description. But the main thing that everyone needs to understand is when the compressor is working and it's working appropriately, the bottom of the TMT is going to touch first, right? So as we're closing this thing down, the inferior surfaces where the bone cuts have been made touch, and then the joint continues to close, and the dorsal surface of the bone surfaces are going to touch, and you're going to visualize that through your surgical approach, and you're going to see that with your eyes. As soon as that happens, you're done. Tightening the knob doesn't close the gap. What it will do, though, however, is it will induce a flexion in the pins. The pins will look like parentheses on the lateral film, and you'll end up with a gappage at the plantar aspect of the joint. So tightening it will cause an elevation and a gap, and it is totally counterintuitive because we're taught if we have a knob, turn it a couple more times and it'll fix the problem. But in this case, it just needs to be kind of snuggled up against each other. So sometimes we refer to these things as the snuggler, and we don't want to overcompress but oppose. So that's what we're looking to do here.
And then these series of x-rays on the bottom, we hear this a lot, spring back, the term spring back, or I lost correction post-operatively. So how would you explain the series of 3 images here to a surgeon that said, hey, I lost correction in my case, or post-operatively?
Well, I'll tell you that there's a high likelihood that either soft tissue releases weren't performed adequately, instruments were used, like Bob said, to kind of force the correction, and then by the time instrumentation is removed and plates are put on, you get this retroactive spring back of the soft tissue tethering the bone, opening things back up again, and then this is what you end up with because it wasn't able to sit back down into appropriate alignment. You forced it there. And so you still have all these opposing forces working at you.
Yeah, another factor that could be here that is that if you look between the middle picture and the picture on the right, it is possible these are slightly different angles, but if you look at it, the intercuneiform joint is opening up, and if that's the case, and you didn't test post-Lapiplasty splay, and your crista is eroded, then those sesamoids can slip around laterally, and now they're hitting the ground off axis, and they're going to push the met up and into varus, which will then, if the intercuneiform joint is unstable. So I can't say it's confirmed in this case, but that's another factor. You got to look for all the elements that were diseased in the bunion. That's why the axial sesamoid would be helpful, so you can see what crystal you're dealing with. And if that's the case, you would have probably put in a dovetail or an M1C2 screw and potentially done an Aiken to make sure that that joint was congruent to its max, so the EHL and FHL pulls were absolutely in line with an absolute rock solid pull.
Yeah, and to speak to that, what Bob mentioned, that image in the center on the bottom, that second X-ray in, that's a supinated foot. So that is post-procedure. Patient is still protecting, they're guarding, they're supinating the foot at the time of the X-ray. But if you do something like that intraoperatively when taking your fluoro images, that's the exact scenario that you run into if you have inconsistency in your process, because it's easy to fool yourself that those sesamoids are in a better position than they are, and that the first MTP is in a better position than it is. And then you get a fully weight-bearing X-ray and you find out that you just weren't really quite sure what you were looking at during the procedure. So something to think about.
We kind of hit on recurrence, letting the instruments do the work. Another, something patients don't want is a non-union, right? So talk maybe through some of these issues that could happen that could potentially lead to that, and how to prevent them.
Yeah, I hear a lot of surgeons tell us that, no, I don't finish straight. I find that to be an inappropriate answer, because it's part of the technique. Anytime you're in the subchondral bone, you need to penetrate below it to get to the vascularity that can come within the bone. So doing an adequate bone prep is important on any arthrodesis. We've already mentioned that if you over tighten the compressor, it's going to cause this elevation to happen. So I think it's something that you have to be really careful about. Placing the instruments at 90-90 is also something to think about. It's not just a term we use to get them spaced out. You're trying to get the tips of those speed plates or the tips of those screws to the center of rotation of this bone, so that they can now work as an I-beam relative to each other. So if one has to fail, the other one would have to fail. If you do not get those, as 90 degrees as possible, you're moving them closer together. You're getting into the same plane of control, and now you're losing the other plane of control. So careful placement of the hardware is really important as well. These steps they're the tedious steps of surgery, the non-sexy part of surgery, but it is the part that is necessary to get good results. Pay attention to those details, especially bone prep, placement of your hardware, things that tend to get overlooked as you move through the surgery.
Yeah, convergence of the plates essentially make the plates act as a hinge, and it's a hinge in which the bone can rotate around. So you lose all the control, and you essentially have now just put one plate in. It acts as one plate. So it's something.
There's a reason why they outlawed three-wheelers. There's a reason why they outlawed three-wheelers. Now we have four-wheelers, because you have to get a four-wheeler to roll. It's a lot harder than to get a three-wheeler to roll. So be very careful.
And the bottom bullet point here in the image, center right-hand side, center one, is the SpeedPlate drill guide, the importance of that being flush to bone and how that could affect construct strength.
Absolutely.
Yeah,
We want the bridge of that plate to be contacting bone. We want the tines fully engaged within the bone, through the cortex into the medullary bone, and the guide itself echoes the bridge of the plate. So when that is in contact, if there's any rocking, shifting, rolling, whatever, if there's any pitching or awing of that plate, then the drill guide, we need to prep that bone, remodel it in order to accept that arc of the plate, so that this way when you actually put the implant in, it's going to sit flush. And that is very important.
Yeah, it's a 3-point bend. So we were all taught about casting and everything else. You got to get that 3-point bend. And if you don't have that in contact, you're diminishing the effectiveness of the dynamization and the stabilization that could come once that plate is activated.
Great. A couple more things here postoperatively. Closure. What are your closure methods? Dr. McAleer, you want to start? I think these are your slides here. What are you doing for closure approach?
Yeah, so we've done a combination of different closure techniques. I think essentially, again, key concepts is touching the patient minimally. Like Bob had mentioned, when I use forceps on the patient's skin, I don't squeeze. I use the edge of the forceps as a hook. Some of our dermatology colleagues will use skin hooks instead of a forceps when they're closing in order to protect the edges of the skin. I've picked up on that in the past as well. But we do use traditional absorbable suture at the patient's joint capsule. We'll close in multiple layers, but I've gone back now just recently to running subcutaneous monocryl, and I haven't been using Dermabond and other skin adhesive glues, fibrin glues at the level of the skin just to seal everything and keep it in place. And we found that that has been nicely successful, and the patients are having finer scars again. But just taking into consideration adequate hemostasis at the time of closure, making sure that if you do seal them closed, that they're not going to end up with a seroma or hematoma at the surgical site, and truly come at this like you would as if you were a plastic surgeon. You know, we want the patient to have an attractive looking scar post-procedure, and rough tissue handling will equal rough scars.
Dr. Santrock, what are you doing for closure?
I echo everything Jody said. A 3-layer closure for me. I do a 0 vicryl deep, a 2 vicryl in the subparticular, and then running monocryl most of the time. If I really am a little bit lucky, I can get a zip line. I'll substitute that for the monocryl instead of the monocryl. I just touch the skin less, and that's a nice little tool to have as well. But another part of the soft tissue handling is putting a good bandage on. It's like wrapping paper to me. It's the only thing they see when they come out. So take your time, put it on without wrinkles, make sure it looks good. I change my dressings the day after. We're probably going to talk about that here in a second, but you know, the handling of the tissues is very, very, very important. And I can't express enough that I think this is where most of these post-op infections come from, is from bad soft tissue handling.
Yeah, so just in summary, wrapping up the intraoperative pearls, and then we'll get in, as you started, on the bandaging, and we'll hit on that as we lead into the postoperative. But anything more to add here in summary for intraop tips?
You know, Lapiplasty is not a long or complicated surgery. We've done a lot of education out there so that you know all the steps, because we looked at every fail point in surgeries that preceded it, and we identified them all. It's really 4 simple steps. You know, you're correcting, you're making precision cuts, you're compressing, and you're fixating. The other 59 steps we describe in there are all the details for you to understand. Don't skip steps, especially x-rays. This is precision surgery at its very, very finest. If you pay attention, those degrees of cuts are down to the 0.5 degrees. That's how precise we're making it. So take your time to do a precision surgery. You will not take a long time. You get fast by doing it efficiently, as Jody pointed out, with a lot of those steps intraoperatively.
All right, so getting into postoperative. So talking about healing, patient experience postoperatively, talk about some of these concepts here, and then we'll get into details on maybe a little bit more of them. I think patient-specific protocols we talked about. You know, are you approaching your male patients differently than your female patients as it pertains to these postoperative protocols?
I know we do. Unfortunately, it seems like if you're going to have a complication, it's going to be with a male patient, unfortunately. So I don't know if it's a compliance issue, if it's a physical size issue, if it's an anatomic issue, but all of our patients, which the majority of our female, we allow them all to walk the day of surgery. You know, between my partner and I, we're approaching about 1,000 cases performed at our facility, and all of them walk between both of us, with the exception of men. We keep the guys off their foot for about 2 to 3 weeks. Really, it ends up being about 19 days post-procedures when we start letting them bear weight. It just tends to keep them out of trouble. We know that when we tell these patients post-operatively, don't walk on the foot, we know they're going to continue to walk on the foot to some degree, but we also know that if we tell them they can walk on their foot, they're going to be doing everything from roofing to, cleaning out gutters to, doing their yard work. So we really try to drive that home, and we always try to make sure that if they're married or they have a significant other, we try to have them come into the office with their spouse or their girlfriend or, what have you, and they will, we will tell the significant other, hey, this is what they need to do, because then you have someone at home holding them accountable during the post-op period.
Yeah, I agree with Jody. I think the most important part there is to get somebody else who's not male, hold them accountable. But I let mine weight bear, but I do force them to use an assistive device, crutches, walker, or knee scooter for the first 2 weeks.
So I think we'll hit on these on subsequent slides. So what I'll do is I'll go to this, Dr. Santrock. These are this is your brochure here. How do you talk about healing and postoperative expectations with your patients here?
Yeah, I finish every new. Thank you. I finish every new consult introducing people to the dovetail way. The dovetail is the name of my practice, and we call it the 3 R's, which is replenish the body, rebuild the injury, and restore the function. And I say, look, we're breaking it down to simple things we learned in medical school. It's biochemistry, anatomy, and physiology, which is my first semester in medical school. And we have to get them to understand that we need you to help us with these steps so that you can maximize your recovery. We're going to use all 3 of these at the same time. We're going to be basically, using vitamins and nutrition to help the biochemistry be right. I'm going to do the rebuild of your injury and changing your anatomy. And then you're going to also be cooperating with the postoperative protocol to keep your muscles physiologically working the right way and promoting the right blood flow and controlling swelling and so forth. And so by doing this, we are able to really drive home the simplicity of the message to the patient and get them to invest in these 3 mindful things. And so we hand out these brochures as part of their package when they meet us, and it drives in all the understanding of how you're going to interact with the other different name brands you might see along the way. And it's been very good for us, and it's made our messaging very clear to the patients, and then I feel like they're getting better investment themselves, which is the whole key factor. We got to get them to invest into their process, because really what Jody and I do and what you do is an hour. You're in there an hour, and the rest of it's up to them.
So then moving in, setting those expectations, you started talking a little bit about this and doing the dressing, the postoperative bandage. Dr. McAleer, I think these are yours. So maybe if you want to go into how you do your dressings, and then Dr. Santrock.
Yeah, so we try not to do too much what we call is dressing origami, right? Where you're kind of folding all the different gauze and kind of layering them in different fashions. But what we do is we take these 4x4s, we open them up, we layer them down as a single unit. I put one splint between the toes, and then I like ABD pads to pad the surrounding areas, just so the patients don't get irritation, the dorsal cutaneous nerves. And then we basically put on a modified Jones compression dressing to the area just below the lower portion of the calf. And we leave the patients in the dressings for the first 5 days postoperatively. And then the dressings come off at their first appointment in the office. My medical assistant typically takes them all off, and then we migrate them towards a showering and just keeping a clean sock on the lower extremity. We typically do stockinette initially for the first few weeks, and then the patients kind of take that on and off as they like to, and they can wash it. We give them multiple pieces, and then we switch them over to knee-high 15 millimeter mercury compression socks, just to help with any residual swelling as they get moving more.
Dr. Santrock, what's yours? I know you mentioned maybe first visit.
I'm a little bit similar, but a little bit different. One thing I just was mentioning before, I think the bandage is important. It's, your iPhone came in a pretty white box. You should deliver the foot to a pretty dressing. It's the gift wrap. It's the only thing they see. They'll judge you on that. Present a good dressing. I do a tweener between the toes and just gauze pad over top of Xeroform on the incision dorsally, and then a light ACE bandage out of the OR up to the same height, but I do not use a Jones compression dressing. I am going to put them in an Iceman cooler type thing. It's an automated circulating cooler device in the post-op area, so they're going to have a little bit more contact with the environment, with the ice. I change my dressings. They're non-weight bearing out of the OR for the first day because they have a block and they're groggy, and then they come in the office the next morning and I change their dressings again. I never used to do that. It's almost more of a social visit to pat them on top of the head and tell them that they did great and everything was wonderful and to reiterate what happened. And we change the dressing because if they go through a few days, it gets that bleeds a little bit, gets that rough, tough tissue. I don't like that, so tough bandages. So I like it to not feel sticky and hard from the dry blood. So they feel like they get a little tender loving care. I've got a boutique practice. It affords me the time to do this. So certainly don't think there's anything wrong waiting 5 days. Point is that when you get to that, and for me, I operate on Thursday, get to the beginning of the week, we're able to quickly move into, they get the boot walker that day after. Jody, we give it to them, like you said, a few days later. But they get that boot walker and they're able to start moving. That's important to me. But it gives us another time to reiterate the ice elevation and walking at least every hour, getting across the room. And so I think that's really important factors there. And I think then not to forget it. Don't pass it off as it's an unimportant thing. The dressings are important.
Yeah, well, with our cam boot protocol, the patients will get fitted pre-op, but the other thing we do at the time of surgery is we give all the patients a surgical shoe as well. So it allows them to accommodate for the dressing for the first couple of days, back and forth to the bathroom, to the kitchen, things like that. And then we do the swap at that 5-day. So then they start depending more so on the boot. So we kind of do a little bit of both.
So kind of getting into those first 7 days in pain management. So they're doing a little bit of weight bearing. What are you doing for that multimodal pain management?
Yeah, so like Bob and I were talking about, we both use a combination of Marcaine and EXPAREL. But so we get them fairly comfortable, but I have the patients immediately start on 800 of Motrin, and I tell them to start taking it even if they don't feel like they need it. I want them to take it for the first 3 to 5 days. I think it's helpful getting ahead of things and helping to decrease any inflammatory reaction that's going to occur in the body, or try to mitigate as much of that as possible. So this way, as the block wears off, they already have something on board, and that helps to kind of quell those symptoms. We also give the patients an 81 milligram aspirin to take every day. We have them do range of motion exercises. They do get segmental compression pumps to help reduce DVTs and so on and so forth. So I keep their aspirin on the low side, but I do think it has a bit of an anti-inflammatory effect there as well. We give the patients typically Tylenol with codeine. Unless they're intolerant, then we'll switch them to Tramadol. But the patients get a small prescription. They usually only take a couple of the pills if they take any. And most of them are asking us, what do we do with these when we're done? Can we toss them out? So we usually will have them return them to the pharmacy and they can destroy them for them if they need be. The other thing we do give all the patients is Zofran. So we don't, pain can induce nausea. Some of the medications can induce nausea. Anesthesia can induce nausea. So we want the patients to have Zofran. So we give them 4 milligrams Zofran ODT sublingual tablets. We let them use those at their discretion, every 6 hours or so if they feel as if they need something. If they're going to take a narcotic, we have them dose themselves about 15 to 20 minutes before, and we find that's helpful also. But that tends to be the extent of our protocol for medication post-procedure and for our pain management.
Ours is not a lot different, but instead of ibuprofen, we use Celebrex. It has a more pain-specific profile for us, and it doesn't have an absolute contraindication to take aspirin with it. So we use a 325 aspirin for our DVT protocol, but we do not use segmental pumps. So we use 325 aspirin and Celebrex starting the night of surgery. Then they are given a narcotic as well. We give 4 days worth of narcotic, but again, day 1, day 0, they don't typically take anything. Day 1, they don't typically take anything. So usually we take them after day 4 or 5, but I've not had anybody take a full 4 days worth of narcotic in years. So we use either Lortab or Percocet as our baseline narcotic, and that's been our protocol as far as that goes. As far as the other supplemental things, like Jody says, range of motion, getting up, walking every hour, limited but distance, but walking somewhere across the room is encouraged after they get their boot on. And we have the biggest thing we're strict about is ice and elevate. Every time we say ice, ice, baby, and toes above the nose, and that's what we got to get.
Question came in, showering. So when is the patient allowed to wash the wound, or any shower protocols?
I'll take that one first. I'll tell you that I tried the Paul Dayton, Mindy Dayton technique of letting them shower within a few days after surgery, and it didn't help me any. I got more questions and more problems with that, especially because I don't know, wherever I've lived, I've not been able to incorporate that with the intelligence of the patients I've been taking care of. So I went back to not showering until the incisions is healed, which is typically 3 weeks for me. So I use a shower cover. That's a cast cover that goes up to the knee on all of my patients, and that's my norm.
Yeah, and so we differ there from Bob. As soon as the patient's dressings are off, we encourage them to shower. We encourage them to take a running shower with no soaking of the foot, no scrubbing of the foot, gentle wash. They can use antibacterial soap, HIPAA cleanse, anything like that would be just fine for us. And we find that it's more comforting for the patients, and also it helps to remove any residual prep and things like that, which sometimes can be irritating to the skin. So I think one of the other reasons we do it is because we want the patients to feel as if they're making progress towards being normal as quickly as possible. So everything from taking your shower to migrating them back to shoes to all the milestones in between. That's one of the big benefits, I think, also from a psychological standpoint.
I think that's a great point, and I think it does matter. Perhaps I get away with not letting them shower because I see them every week in my office, and I clean the foot personally, or my assistant cleans the foot. So we're cleaning it down with aloe wipes and cleaning up that skin personally ourselves. So maybe we're getting away with it because we see our patients day one and then every week for 3 weeks.
Yeah, you're doing it for them. Yeah, and
We're doing it for them. Yeah.
in a controlled fashion. Yeah.
So as we kind of go into the next slide here, which we've hit on, here and there, a question came in on, Dr. McAleer, you said you're doing the surgical shoe initially and then transitioning them to the boot. The question is, are your patients still compliant with weight bearing in the boot when they have both? He says he always uses a boot, but feel like if he gave his patients both, they would never wear the boot.
Yeah, I think that's a really good point. And we do have a very detailed lecture with the patient. Essentially what I tell them that the surgical shoe is intended for is for them to go to the restroom in the night, because we know that patients will cheat in the evenings and they will either walk on their heel without their boot, or they may get up on crutches, but the patients are groggy, they're tired. We don't want them to have an accident if there's clutter in their bedroom, if they don't have a clear path to get to the restroom. And we've had incidences where patients have fallen not wearing their boot, or tripped on something not wearing their boot. They had like literally no protection. And so we'd rather the foot be squarely on the floor for those trips in the night. So we tell them the shoe is for the evenings. The shoe is intended to get up to for that rush to the bathroom, so you don't have to undo and do all those straps. We don't want you sleeping in the boot. But during the day, it's intended that you wear the boot, and the only exception is for the first several days until we see you back in the office. And during that period of time, patients, you find that they're trying to be very aware of protecting their foot. It's all fresh, it's all new. They're concerned, they haven't seen what their foot looks like. They're not totally psychologically comfortable with the situation yet. So most of them are going to self-limit, and the shoe is going to be just fine. And then we kind of lecture them a little bit afterwards, just kind of reinforce that messaging.
Yeah, I don't give a post-op shoe, but I tell them they don't have to put the boot on to go to the bathroom. If it's bed to bathroom is just across the room, I don't tell them just go in your bandage, weight bearing on your foot. It's fine. And we have been. It's a little bit unprotected. It's a little bit unprotected, but I also carry my iPhone without a case on it.
Yeah, but Bob, you know this, Paul Dayton, him and Mindy do that all the time. They tell the patients just walk around the house in their bandages full time.
Yeah, I tell people that you are weight bearing from day one of surgery, but what I expect in the first 2 weeks is bedroom to bathroom, couch to kitchen, and curb to door. And that's your extent of your walking, and you should do it every couple hours throughout the day. And if you're in bed at night and you want to walk to the bathroom, or you want to stand in the shower without your boot on, perfectly fine. I don't have an issue with that. But if you're going further than that, you need to put your boot on. So if you need to go a little further than curb to door, and you got to go all the way to the front of the church, you're going to have to put your boot on. You're going, so I tell people boots on if you're not going just across the house to the bathroom.
Yeah, and we also encourage the patients. We want them up and moving. So we tell them one of the benefits of the surgery and of the procedure is that they can weight bear. We want them to weight bear. It helps to stimulate the surgical site. It helps to stimulate the fusion site. It also helps to pump fluid, swelling out of the foot, out of the leg. So all those are positive benefits of them moving. Now, you don't want them standing in a static position where gravity is taking effect and pushing all that fluid down, all that hydrostatic force down onto the foot and the ankle. But motion promotes betterment of the surgical site. So something also to kind of have that conversation and promote it.
And then as you're getting out of those initial few weeks, getting them back to normalized activity, would you both say that what's on the screen, these second 2 bullet points here, that's your standard protocol? Do you deviate from this at all?
Yeah, we're right at just shy of 6 weeks. So we're usually 5 3/4 weeks the way the days fall for us with our post-ops, where the patients transition to running shoes. And then we tell them at that 6-week mark, essentially, that they can walk for leisure. We don't want them, power walking hills, doing anything too intense where they're losing their breath in that capacity. But walking for leisure, we tell them they can use a stationary bike. We tell them that they can use a rowing machine. We tell them also they can go swimming as long as their incisions are healed, and that they are not swimming in like the Lake of the Ozark, but rather like a pool or a controlled environment that belongs to them. And we also let them do weighted upper body exercises from a seated position with the leg extended. So even like if they're doing something like bench press, they can't have the foot on the floor for it, even if they're laying back on a bench. We want the foot straight out so that they're not gripping the ground with the surgical extremity.
Dr. Santrock?
We allow all upper body exercise. Essentially from day one. We allow them to elliptical trainer and bicycle from day one if they wish. We allow them to do swimming as soon as their incision is healed around 3 weeks, and we don't allow running and jumping until we get to 4 months. So essentially, I'm basically the same as Jody, except for I start those non-impact lower extremity exercises earlier, and that right after surgery. Very few people do it right after surgery.
Dr. Santrock, didn't you just have one of your SpeedPlate patients run a 5K 5 months?
Yeah, she ran a 5K 5 months out to the day. Ran it. It was a full runner competing for the 5K. Yeah, it was 5K. Yeah.
That's great. So rehab exercises, Dr. McAleer, I think these are part of your protocols here. Talk about these, and then Dr. Santrock, are you doing any sort of rehab or exercise regimen after this?
Yeah, so these are just basic exercises, and the intent of the exercises are to get the patient to do any type of range of motion and mobility when they're at rest. So we encourage them to do these several times during the course of the day. So we tell them once in the morning, once at lunch, once in the early evening, and then once before they go to bed. So we try to get them to do it. So some of the patients tell us that they do it with such great frequency, they even do them in their sleep, which I love. But it really just helps, again, with inflammation, swelling, pushing out fluid, and also maintaining mobility. Because one of the things that we have to fight with a little bit is if some of the patients develop some degree of scar tissue at the first MTP following that lateral release. The lateral release is very necessary, but we want to make sure that that tissue is getting laid down nicely and that they're not getting any adhesions within that joint or around the joint. So we want to encourage that mobility. And this is, we give all the patients a very specific postoperative packet. So they follow from day to day, week to week, what to expect at each and every appointment. And so these exercises are included in there, and we encourage them to start them just right around that day 5 post-procedure when their dressings come down.
Yeah, the only part of this that I do is I do tell them to passively move their great toe up and down with their fingers. I tell them hold on to it, tell them where to hold it, and to work on range of motion, the MTP joint, dorsiflexion and plantar flexion. And I ask them to do that every hour during the day, starting right away. So I think that for the same reasons that Jody said, I don't do the rest of it. I just want them to do at least that one, the toe mobilization.
Question came in going back to the swimming or the elliptical, maybe starting with Dr. Santrock. If they're doing the elliptical early on or even from day one if they wanted to, are you recommending that they do that in the boot? And then same thing with swimming. Do they need to wear anything while doing either of those activities?
Yeah, so elliptical, trainer, and bicycle, I ask them to wear the boot for the first 2 to 3 weeks, or usually 3 weeks. That's about the time their incisions have healed. Then I tell them they can be out of it if they want to do it, but they can't usually get into a shoe. So it's usually they'll stay in the boot for the first 6 weeks while they're using it. But if they could get into a Birkenstock sandal or something like that to do the elliptical, I would let them at that point. Swimming, they're not wearing a boot. They're doing swimming like swim aerobics, which is real popular down here in the retirement community I live in. They can start that as soon as the incision's healed, which is for me usually typically 3 weeks. But I'm seeing them every week, so I can judge if the incision's healed. But I don't make them wear a boot.
Great transition. Wrapping up here, last slide. We've kind of hit on this throughout the evening, but the timing of your post-op visits, the text on the left, Dr. Santrock, if you want to start, these are yours.
Yeah, day one is really, like I said, I just want to have a chance to talk to them while they're conscious and not drugged up and see their face and change their dressing and make them feel real good. I do surgery on Thursdays typically, so it's seeing them Friday morning and tucking them in for the weekend and giving them their expectation and reiterating instructions again. I see my patients at week one again to then weekly thereafter if needed. Some patients week one, they're doing great, they're young, they're healthy, they'll come back in 2 weeks, especially if they're far away. If they are far away, I'll do telemedicines. It makes it easy. I send them with dressing, show them how to do it, and then they'll do it with us on the telemedicine visit. I have a very boutique practice. A lot of social time is really what these are for. They're not 100% necessary, but it does let me see the wound and see the swelling. Most importantly, that's what I'm really looking at in the first 3 weeks to see if people are really controlling the swelling, which I think is the biggest predictor of postoperative success. Is swelling control. Then at 6 weeks is my first set of x-rays. They can return to shoes at that point. I get x-rays again at 16 weeks, which is again x-rays and return to active sports, running impact sports at that point. And I see them at 6 months and 12 months are almost just for me, although I like to confirm the healing completed. But those are for me. If I used to have a weight-bearing CT scanner and would get them at 6 months and 12 months, I do not any longer have access to one. So those are just holdovers with x-rays being taken at that 6 month and 12 months again.
Dr. McAleer, your timing here?
I think all the points that Bob made, we're probably doing very similar things. It just, very slight differences in the time points, but we're seeing these patients back for all the basic essential things that Bob just stated. So I don't want to go too far into depth on this, but we do have them back the first week. Dressings are down. We're taking a look at the patients. Stitches are out at 3 weeks. By 6 weeks, we're migrating them back to shoes activity. And then by week 16, we're basically telling them they can do anything and everything they want, including high impact activities. The purpose of what we do, and I think really what's more important than like giving you specifics is everyone, when they're treating these patients, everything should be very dialed in, and everything from the pre-op exam to the intra-op process to the post-operative care should be the same, and it should be very reproducible. And I think that allows each practitioner to kind of see what's working best in their hands, what works best for their patient population and their particular geographic region, and it allows them to continue to fine tune the best protocols that they can find, and it's consistent. So rather than just kind of saying, well, all right, you look good, I'll see you in 3 or 4 weeks, and let the patient pick, we have very specific dates. You're coming on this date. We know when they're coming in. And what we do at each appointment is very important, because then the staff also knows, so it makes everyone flow more efficiently as you're working through the process. So I think that's the take-home message here, more than my timing or Bob's timing or what have you. Just getting something down that's algorithmic that you can do over and over again.
You can actually see it on the bottom left of the first image here, but driving. So when are you letting your patients drive? Can they do it in the postoperative shoe? When would you recommend or allow your patients to drive?
We tell the patients if it's a right foot procedure, we want them out of the boot. So we tell them 6 weeks. There are some studies on this as far as stopping distances and ability to sustain pressure on a brake pad or brake pedal rather. If it is their contralateral limb, their non-driving foot, we'll let them drive as soon as 2 to 3 weeks, as long as they're not taking narcotics for short trips, because we don't want their foot hanging down in a dependent position for prolonged periods of time. We do have patients that will drive anyway, and they say that they can drive with their opposite foot. We hear this all the time. I have had 2 patients. One drove their car into someone's living room, and someone else rolled over their son and pinned him up against the wall in a garage. This is Missouri, folks. This is the home of the chimp nation. So we do have a different breed of people out here, everyone from professional to, oh my God, what is happening? So, but we try to.
So driving.
So I'm afraid my kids drive, my daughter drives. I'm worried for her safety, so I don't want my patients out on the road before 6 weeks. I can keep her safe. I've done my duty as a parent.
But left foot, it doesn't matter.
I don't, yeah, left foot I'm not too worried about as long as you're not taking narcotics. Yeah.
One more question. So these documents here, these images, Dr. McAleer, these are yours. These are from your patient, what you give to your patients. Surgeon asked, would you be willing to discuss these, to share these, maybe suggest a peer-to-peer here? What would you say to that?
Yeah, I'd be very happy. These are my particular, this is my particular booklet. We give patients, some of those graphics like the range of motion exercises, we give them representative examples of a pre to post procedure for their particular procedure, whether it be an MTP, a TMT, a double, a quad, a 3-2-1. But again, all of the protocols essentially are the same. So the only things that change are some of the verbiage in the cover letter, some of the radiographic images, and we also show them where their incisions are going to be placed by showing them representative examples of that. But yeah, I'm usually very happy to discuss this, and I'm also happy to share because again, if we're all doing good work and we're all kind of collaborating and working together, if you're doing an excellent job and I'm doing an excellent job, it gives the process and the procedure a good name amongst patients. And people obviously talk a lot, and there's lots of online forums regarding bunion surgery and everything else. So we want that good information out there, and we want people to feel as if they're being well cared for.
A question came in earlier and felt that it was better for the end, but the question was, what percentage of your patients are you doing, mini or micro incision approach, and what particular criteria are you looking at for selecting these patients?
So Bob, do you want to, you're in the Florida area, so our answer is going to be obviously, I think, different. Do you want to talk about Florida?
Yeah, I think that the vast majority of our patients, so I'm using all the patients, I'm using the micro instrumentation. I don't do a pure micro approach of 2 centimeters, and unless it's requested and appropriate. But I typically do about a 3 centimeter to 3.5 centimeter incision on my typical Lapiplasties. Gives me plenty of room. I feel it's safe for most of my elderly patients to do that. With the micro instruments, I feel like I could drive a truck around the 3-in-1 with a 3.5 centimeter incision. So I feel like it's pretty good compromise. Truthfully, when you get done with a 2.5 centimeter versus a 3.5 centimeter, you can't tell. It's a pretty small incision once it's healed. So, but the less trauma, the better. I feel like if the tissue's compliant and I can easily mobilize, then I feel good with the smaller incision I can get away with. But I always use the micro instrumentation because it allows me to get as small as I possibly think is necessary in each patient.
So no specific criteria here, just.
Well, I have specific criteria of who I will not do it on. Like the specific criteria would be people that have previous wound healing issues, people who have elderly age and less compliant skin. You're going to make the tissues if I have to pull and tug on the tissue, I'm going to lengthen it. So I never promise somebody they're going to come out with a 2 centimeter incision. I will tell them I try, and they typically are very young females that we try to do that on, where cosmesis may be a part of the request. But I'll tell them if I'm going to pull on that tissue, I'm going to expand this tissue because I don't want you to leave you with an ugly scar.
Dr. McAleer, anything to add?
Yeah, no one in our particular geographic region is usually going to come in and ask for a micro incision. Patients tend to be very practical where we live, and they come in with concerns of pain, discomfort, and they just want to be fixed. So when the patients are coming in, incision size is really never a conversation that we even have with the patient. I pick and choose depending upon the patient and all the factors from an anatomic standpoint that Bob had mentioned. I pick and choose who I'm going to make a larger or smaller incision on based upon those factors. But patients are usually more interested in where is the incision going to be. We tell them they're going to have a scar. Nobody really cares. And they say, well, but I'll be fixed, correct? And then we say, yeah. So, we're dealing with a different crowd than you'd see maybe in, Miami or New York or, Arizona, like out in Phoenix or Scottsdale areas. It's a working community, it's a practical community, and they just want to be better so they can go back to living.
Another question that's come in terms of your hardware, we released SpeedPlate just about a year ago. What are you, both of you, using or your preferred method of fixation? Is it a combination of both? What are you trending to these days? Maybe Dr. Santrock, start with you.
Yeah, I really find the SpeedPlate to be, what I would prefer to use at all times. I don't have access to it at every facility I work at based on contracts and such. So I do use a combination of both. But every time I use a SpeedPlate, I feel like a hero. It's just so satisfying to use. And so it's my trend is that I would go to SpeedPlate by default if I had no other factors based on like facility contracts and such. So I use my typical go-to would be using the 18 by 17 and the lessers for the adductoplasty. I use the quad dorsally and the 18 by 14 medially for my Lapiplasty, but I always put an M1 to C2 screw in anytime I use a two-prong SpeedPlate on the first column. And then my construct I use for the MTP would be the dual quads on the MTP joint. That's what I find. And if I don't have SpeedPlate available, I will be defaulting to the S2 plate because if I had the SpeedPlate available, I have the S4 available as well. So it's the same as the opposite. If I don't have SpeedPlate, I don't have S4 in those facilities. So S2 is my combination that I typically use elsewhere.
Dr. McAleer?
Yeah, MTP, 2 quad speed plates, lessers, quad speed plates, first TMT, depending, I use a combination. So if I'm doing a true micro in a small petite female patient, I'm using 2 dual prong, usually short and long tine, and a crossing screw. If it is more of an open approach, I'm using a quad dorsal lateral and a 2-prong medial with a crossing screw. If it's a male patient and they have larger bone stock, I'm doing 2 quads typically without a crossing screw, but if there's any intercuneiform instability, I'll drop one in as well.
Yeah, I did fail to mention if I have a cosmetically inclined patient doing a true micro, it's two-prong SpeedPlates with a crossing screw.
Great, thank you so much. Everyone, thank you. If there's any other questions, please feel free to type those into the chat. This has been incredibly informative. I hope you all gained a lot of valuable insight, pearls, tips. I'll do another plug. We've mentioned peer-to-peer calls on these webinars before, but our faculty surgeons do a number of these every single week. So if you have a particular case preoperatively that you'd like to discuss or postoperatively to review, please reach out to your local representative and get one of these scheduled. I know both of you do these regularly, guys, and I don't know if you just want to briefly speak to how valuable they are, but those are always available to you.
Yeah, I do them almost I'm sure I do them every week, a couple times a week, a lot of times, and they're valuable to us because we learn from you as well, and so it contributes to the overall success of this system. They can be anything from a single topic that you just want more information on, a bullet point of something you've learned that doesn't make sense to you, all the way through a case to discuss, or a complication, or a concern you have seeing in your trends, or something that's new and novel that you want to discuss. So happy to do it, and we love doing it, and Jody does a lot of them as well. So we encourage you to continue to ask for them.
Yeah, talk to me about bunions, because my, as I always say, my wife and my family are tired of hearing about them. So give me a call.
Thank you everyone for joining. Appreciate your participation. We have a few medical education events left throughout the year. So if you're interested in attending any of those, please reach out to your local rep. For any other questions, comments, concerns, please reach out to the medical education team outside of your local rep. We thank you for joining us, and we'll see you on the next one. Thank you, everybody.
Yeah, thank you.
Good night.
Good night, everybody.